Welcome back. In the chapter of health programs in India, in today's session, we will deal about the reproductive and child health program. What is RCH approach? The reproductive and child health approach has been defined as the people having the ability to reproduce and regulate their fertility. So, people having the ability to reproduce and also regulate their fertility. Women who are able to go through pregnancy and childbirth safely. So, the RCH, Reproductive and Child Health, how do we define it? This program is defined as the people having the ability to reproduce, to regulate their fertility, women who are able to go through pregnancy and childbirth safely. The outcome of pregnancy is successful in terms of maternal and infant survival. When do we say the outcome of the pregnancy is successful? When the mother and the infant both are healthy and safe. So, the outcome of the pregnancy is successful in terms of maternal and infant survival and well being. And couples are able to have sexual relations free of fear of pregnancy and of contracting diseases. So, the couples are able to have free of fear sexual relation. Okay, free of fear. Fear of what? Fear of contracting diseases like sexually transmitted diseases or fear of contracting the pregnancy. That is RCH's approach. The main approach is that people should be able to reproduce. Once they are able to reproduce, the pregnancy and the childbirth should be safe. Then the pregnancies should be very successful in terms of maternal and infant survival. And the couple should be able to have sexual relations free of fear of contracting diseases or fear of having conceived or becoming pregnant. This is the main approach, providing these things to the people. Reproductive and child. So, under reproduction, the pregnancy comes. Child, the childbirth should be safe. And the infant and the child should be safe. And we have reproductive, right? So, we also have the sexual relations which are free of fear. Moving forward to the RCH Phase 1. So, under Reproductive and Child Health Program, we are beginning with RCH Phase 1 in this session. In the next session, we will deal with RCH Phase 2. Beginning with RCH package, the program was incorporated the components which are relating to the child survival and safe motherhood. So we are very obvious from the previous slide we got to know the main focus, the main component is the child's survival and the safe motherhood. Second, family planning. They should have free of fear sexual relation, which means the family planning. So they will use contraceptives, the spreading awareness about the contraception, encouraging the people to adopt the contraceptive methods. So the first objective or the first component of RCH is the child survival and safe motherhood. The second component is family planning. Thirdly, prevention and management of reproductive tract infections, sexually transmitted diseases, AIDS, etc. If the STDs, sexually transmitted diseases occur, the prevention and management is other component. And the last component is client approach to the healthcare. Clear, guys? These are the 4 components which are incorporated under the RCH Phase 1. Okay? Now, we see the Phase 1 interventions in all the districts. So, based on the components in all the districts, these are the interventions which are done under the RCH Phase 1. In the first place, the child survival intervention. The child's survival intervention, what will we do? Provide immunization, vitamin A. Vitamin A is provided to prevent the blindness. And we have oral rehydration therapy to prevent dehydration. And then we have prevention of deaths due to pneumonia. child. Okay, so what are the major things which we have under the child survival interventions? The first thing is immunization, followed by immunization, vitamin A to prevent the blindness. We also have ORS, oral rehydration therapy, and then we have in order to prevent the pneumonia, we have this ORS or oral rehydration therapy, and we also prevent the deaths which are occurring due to pneumonia. Secondly, we have safe motherhood intervention. So the first thing was the child intervention. Second comes motherhood intervention. In the motherhood interventions, we have antenatal checkup, immunization for tetanus to the mother, safe delivery, anemia control program. So in order to cut down the anemia in the women, we have anemia control program. So under the mother, regarding the mother, what are the interventions? The first thing, antenatal checkup, anemia control. In antenatal checkups, we see if the mother is having anemia, we will control it. So antenatal checkup, anemia control, we provide immunization for the tetanus. So how can we relate it? Antenatal checkup, provide immunization, control and check the anemia, and then perform the safe delivery for the mother. Next, implementation of target free approach. So it's the interventions is conducted in all the districts, and it is implemented of target free approach. High quality training is given at all the levels. So the people who are involved in providing these services, high quality training is given to all those health workers. Following, we have IEC services, where information, education and communication activities are carried out, followed by the specially designed RCH package for the urban slums and tribal areas. So this hard to reach areas like the tribal area, hilly areas, slums, these people, we have specially designed RCH packages. District sub projects under the local capacity enhancement. We also have the sub projects which are under the local capacity enhancement. The reproductive tract infections STD clinics are established at the district's hospitals. We have this clinics where it is not available, we have this clinics. Okay, when it is not available in the district hospitals, we have this RTI STD clinics at the district hospitals, specialized ones. And then we have the facility for safe abortions at the PHCs, at the primary health care centers. We are providing the primary health centers with the required equipments, with the contractual doctors who can perform the safe abortions. MTP, medical termination of the pregnancy, abortion can be done. That facility is provided at the PHCs. Enhanced community participation via the IEC activities, by giving the right prompt information, educating the people, and then having the community's involvement, we can enhance their participation through the panchayats, women groups, non-governmental organizations, which is nothing but the NGOs. Adolescents health and reproductive hygiene. So RCH phase 1, the intervention also includes the adolescents health and reproductive hygiene. Clear, guys? Is this clear? So what did we see? Let us try to summarize. Okay, the RCH phase 1, let us summarize here. So what are the points we saw? The RCH phase 1. What are the main interventions in RCH phase 1? The first thing is child survival. Okay, child survival intervention, under which we had immunization, vitamin A, ORS, and then we have oral rehydration therapy, ORS, prevention of the pneumonia. Second, we have safe motherhood. For the safe motherhood, what did we see? We have provided this antenatal checkups, correction or control of the anemia, immunization for the tetanus, safe delivery. Followed by, we are having a target free approach, providing the quality skills to the, and as well as the training, quality training to the health workers. Followed by IEC, information, education and communication. By this information, education and communication, you can say that there is enhanced community participation through the panchayats, women groups, NGOs. And next we will discuss about the reproductive tract infections, STD clinics at the district hospitals. Then we also have this MTP, medical termination of pregnancy abortion facility at the PHC. So these are the important things which we studied under. Along with it, the adolescents health and reproductive hygiene is also focused about. So these are the interventions at the district level at all the districts in the RCH phase 1. In the selected states, now followed by in few selected states, they have these specialized interventions. So let us see what are the advanced interventions. Screening and treatment of RTI STD at the subdivisional level. In few selected states, they have the screening for the STDs or RTIs, and also providing the treatment at the subdivisional level. Providing the emergency obstetric care at the selected first referral units. So we have this. So once the case comes to the PHC, the primary health center, if the case is quite complicated, it cannot be dealt, we will refer. First referral unit is the CHC. We will refer the case to the CHC at the district level. So the emergency obstetric care at the selected first referral units. Essential obstetric care. We are providing emergency obstetric care and the most required essential obstetric care by providing the drugs. How can we provide this essential obstetric care? By providing the drugs, and the staff nurse at the PHCs have to be trained. And additional ANM at the sub-centers. So we are providing this additional auxiliary nurse midwives are appointed at the sub-centers, especially in the weak districts, so that they can ensure this maternal and child health care. We are appointing additional auxiliary nurse midwives at the sub-centers. Under the PHC, we have 6 sub-centers. So below PHC level, below the primary level is the sub-center level, wherein we are providing the additional ANM workers so that they can provide the MCH care. Improve delivery services and emergency care. How can we improve the delivery services as well as the emergency care? By providing the equipments kits, intrauterine devices insertions, auxiliary nurse midwives kits at the sub-centers. So by providing the drugs, by giving the required equipments to carry out the delivery, as well as the emergency care is provided by the ANM kit. Auxiliary nurse midwives will have the kit for the emergency care and the important delivery service. Following, the facility of referral transport for pregnant women during emergency. So if an emergency arises, then we need to provide the facility for the transport of the pregnant women. When the pregnant woman is transferred, when she is referred, this transportation facility has to be provided to the nearest referral center. Through the panchayat, she is being transferred to the nearest referral center in cases of the weak districts. So these are the new interventions in the selected states. So let us see what are the new interventions. Let us try to recall the points we studied. The first point, what did we see? Screening was done, treatment was given for the sexually transmitted diseases, reproductive. Then 2 things, obstetric care. In the obstetric care, essential obstetric care and emergency obstetric care. Essential and emergency obstetric care is provided, followed by the additional appointment of auxiliary nurse midwives at the sub-centers level. And by all this, we are improving the delivery services, emergency care by providing the drugs, equipments, ANM kits, etc. Also, lastly, the referral transport is done to the nearest referral center. Okay, the referral transport is provided to this pregnant women to the nearest referral center. Moving to the major interventions under the RCH phase 1 is the essential obstetric care, emergency obstetric care. So again, it's the same thing. essential obstetric care. Let's see, why do we give this essential obstetric care? So that the basic maternity services are provided to the pregnant women. That is the early registration of the pregnancy within the 12 or 16 weeks. We need to provide the minimum at least 3 antenatal checkups by the help of this ANM or the medical officer, so that we can monitor the progress of the pregnancy. If any risk or any why do we provide antenatal care? So that any risk or the complication arises, we can detect it earlier and provide the appropriate care. Also, we can refer the patient in time. Then the provision of the safe delivery at home or in institutions, that is the essential. Okay, we need to provide the safe delivery at home or institution, and providing the postnatal checkups, at least 3 postnatal checkups, so that we can detect any complications and how well the recovery is occurring. Next, we have emergency obstetric care. Essential, what do we have? Under essential, we have antenatal checkups, postnatal checkups, and then we have the provision of safe delivery at home or in the institutions. So these are some of the important things. Next, we have what is the second point? Emergency. Under the emergency obstetric care, whenever the complications which are associated with pregnancies come up, then we have to opt for an emergency obstetric care, so that we can prevent the maternal mortality as well as the morbidity. That is by referring to the first referral units, and we also have to strengthen the referral units by providing this emergency obstetric kit, equipment kit, and the skilled manpower on contract basis. Okay, in cases of emergency obstetric care, this traditional dais are there, right? The traditional birth attendants, the dais who are performing this home deliveries, they also play a very important role during the deliveries which are occurring at home. Okay, how can we improve this emergency obstetric care? Emergency obstetric care, it is very important intervention. It is very important to prevent the morbidity and mortality. Under this program, we will support with the equipments, providing these kits, that is to the first referral units. We strengthen them by providing obstetric kit, equipment kit, by provision of the skilled manpower. Next, we have 24-hour delivery services at the PHCs and CHCs. To promote the institutional deliveries, we have to provide this 24 hours delivery services at the PHCs as well as the CHCs. Okay. Next, we have the medical termination of the pregnancy. The Medical Termination of the Pregnancy Act was passed in the year 1971. What was the main aim? Aim is to reduce the maternal diseases and deaths. The aim is to reduce the maternal morbidity and mortality from the unsafe abortions. If she herself induced the abortion, it can land up into septicemia, septic abortion, so her toxic shock syndrome, death. So we have studied all of that in our previous obstetric OBG, and now we see that in order to prevent such complications and deaths and diseases of the mother, we will go for the safe medical termination of the pregnancy. So this MTP, this central government of India, the central government of India has provided this assistance for the MTP by providing the required equipments, by engaging the doctors, training them in MTP, so that these doctors will make a visit to the PHCs on the fixed days and they will perform the MTP. Okay, government has encouraged MTP by providing the equipments, by engaging the doctors to make a visit to the PHC and perform the MTP. Followed by the control of reproductive tract infections and sexually transmitted diseases. So this has been planned and implemented in collab with the NACO, that is National AIDS Control Organization, wherein the assistance is provided by the central government again in training the manpower and providing the drug kits, including the disposable equipments are provided by the government. We also have this lab technicians on the contract basis who will test the blood, urine, and the RTI and STD tests. Followed by immunization, the Universal Immunization Program. It was launched in 1992. The RCH program was launched in 1997. And now both of these are currently under the National Health Mission, the Universal Immunization Program. Immunization is provided under the Universal Immunization Program. Followed by the drug and equipment kits. So the drug and equipment kits, the equipment kits are supplied at the various levels as follows. At the sub-center level, we have the drug kit A, drug kit B, and midwifery kit, sub-center equipment kit. Then the United Nations Office for Project Services. So these are the ones who are providing the kits. And we see at the PHC's level, we have PHC equipment kit. At the CHC's level, we have kits which are ranging from kit E to kit P. Then followed by the essential newborn care. We are providing the essential newborn care. The primary goal is to reduce the perinatal mortality and morbidity. So you just remember this drug and equipment kits are provided, okay, at the various levels. In depth, I don't think so anybody will ask you in your exams. For now, you remember the essential, the main headings, the essential newborn care. The main component is we need to resuscitate the newborns who are suffering with asphyxia, preventing the hypothermia, infections, and referring the sick newborn. These are the main things which come under the essential newborn care. Next, the diarrheal control, disease control. How can we control the diarrhea? By providing the oral rehydration solution. So we see oral rehydration solution or oral rehydration therapy, wherein India is the first country in the world to introduce this ORS. Okay, India was the one who introduced this oral rehydration solution. Zinc is also used as an adjunct to ORS for the management of the diarrhea. You can also remember this. Zinc is also used. Addition of the zinc is resulting in the number and severity of episodes and duration of diarrhea. So the addition of zinc with ORS is also done. Prevention and control of vitamin A deficiency in the children. We have to prevent and control vitamin A deficiency in the children. So under the program, the doses of vitamin A is given to all the children under 5 years of age. The first dose is 1 lakh units. It is given at 9 months. Okay, the first dose. So we'll see here. Vitamin A is given. Prevention and control of vitamin A deficiency in children by providing vitamin A to the children, and they are provided to all the children who are aged under 5 years. The first dose is 1 lakh units. Okay, the first dose 1 lakh unit. It is given at 9 months. Okay, first dose. Okay, let us write it here. First dose 1 lakh unit given at 9 months. Okay, next we have the, along with the measles vaccine, we will give the first dose, and the second dose, that is 2 lakh units, is given after 9 months. So the second dose, that is 2 lakh units after 9 months. Okay, subsequent doses 2 lakh units are given at 6 months interval up to 5 years of age. Okay, there are subsequent doses. The subsequent doses will be given from 6 months, given at 6 months interval. After the 9 months, again after the 6 months interval, up to the age of 5 years of age. Every 6 month interval up to the age of 5 years, we give the subsequent doses. Yeah. Followed by, under the program, doses of vitamin A, what we just saw now. They are given to all the children under 5 years of age. The first dose is 1 lakh unit given at 9 months of age along with measles vaccine. The second dose is along with the DTP and DPT and OPV, oral polio vaccine booster dose. We are giving the second dose, that is at the 2 lakh unit. It is given after 9 months. Okay, 2 lakh units. Then the subsequent doses, again 2 lakh units, they are given at every 6 months interval up to the age of 5 years. Acute respiratory diseases control. Okay, we are controlling the acute respiratory diseases. So the standard management includes cotrimazole is being supplied to the health worker through the CSSM drug kit. Prevention and control of anemia in the children under this program of control and prevention of anemia. We are also preventing and controlling the anemia in the children. The anemia in the children is controlled under the program control and prevention of anemia. The tablets which are containing 20 mg of elemental iron and 100 mcg of folic acid is given for 5 years. So we see iron and folic acid supplements. Iron is, we have 20 mg of iron, 20 mg of elemental iron and 100 mcg, this is mg, 20 mg of iron, 100 mcg of folic acid is given for 5 years. 30 mg of iron, we give 30 mg of iron and 250 mcg 6 to 10 years for 100 days are provided at the sub-center level. The health workers to provide 100 tablets to the children clinically who are found to be anemic, they have to be provided with 100 tablets. Followed by the training of the DIEs. The training of the DIEs, a scheme for the training of the DIEs is initiated and the scheme is implemented in 18 states. We see that it is extended to all the districts today. The main aim was to train at least one DIE per village. The objective to train the DIEs is to provide the safe deliveries. Moving on to the RCH Phase 2. So let us stop here. In the next video, we will discuss about the RCH Phase 2. I hope so far it is clear, the RCH Phase 1. If you have any doubts, put it in the comment section. And if you like the video, hit the like button and subscribe.